let's talk about the respiratory system first. If we go back to our A&P and our physical assessment classes, you probably remember the anatomy itself, right? And the importance of CO2, O2, and the importance of hypercapnia. Hypercapnia meaning excess CO2 as a drive to breathe, not hypoxia. And then about COPD is where their drive to breathe is hypoxia, so you do not put them on oxygen. You probably learned that in your 1130 lab too, right? Okay, I see a lot of nodding heads. So without going too much into how our body tries to balance acid base with O2, CO2, without going too much into the pH, which you're probably learning now, right? HCO2, PaO2, and its importance, and without just trying to refresh yourself about modified Allen test that you would do for the arterial blood gases, right? Those are all some things you've learned in the past. But the goal is here to see how, when patients present with some problems, from a respiratory angle, what type of medications can we give them, right? So that being said, when patients have respiratory problems, they could have either upper or lower respiratory. So if you think of upper respiratory, it's usually sinus problems or upper respiratory infections and allergies and things like that, right? If you think of lower, COPD, asthma, classified either as hypersensitivity related conditions like in asthma where there's mucus formation, versus in COPD there's obstruction of the alveoli, which leads to holding off the CO2, them not being able to release it, right? So these are basic diseases that we generally think about when we think of respiratory medications. But then respiratory distress is such a huge thing, and with the COVID-19 now, that's a huge concern, right? To immediately open up the airway and maintain them, and to have to intubate them, it's such a neat thing, to have to help from the healthcare perspective, the respiratory therapists, the ICU physicians, nurses, and everybody, right? The EMT, everybody who's trying to help with this, right? I don't think we could do enough justice trying to talk about that today, but I think if we look at this part where we talk about upper respiratory drugs, right? The first thing that we see mostly in this country is allergies, right? So I'm going to share the screen to see if you can look at my screen for respiratory drugs. So you probably are aware that in the spring, many of them are allergic to pollen, right? And sometimes in the fall, many of us could have allergies to things like ragweed. Some people have allergies to dust, mites, and things like that. So when we have allergies, our body secretes histamines. Histamines are secreted not only during pain, but also when we have some type of exposure to allergies. You probably learned about IgE and those antibodies in your pathophysiology, right? So what happens is when we are exposed to some allergies, if we are sensitive to those things like pollen or dust, we might have a reaction. So what happens is our body, the skin, or the GI tract, or the respiratory system might show some type of reaction. You might have itching, you might have sneezing, coughing when these histamines are released. So when those histamines are released, you have, because those are for inflammatory substances, they cause us to have some congestion, some itching, and some unpleasant symptoms. So there are different types of histamines in our body. So the first is the H1 blockers. The histamine type 1, that they work on the histamine receptor 1. And then we have H2. The H2 is predominantly present in the stomach. I just told you that the histamines are present in 3 areas: the skin, the GI, and the respiratory tract, right? So if you think of the H2, H2 is only in the GI. H1 is present in the skin and in the respiratory tract. You see why this explains why you would give medications for drugs related to the skin and the respiratory using this So if a patient has itching in the skin, we give them Benadryl, right? Or when we have, or if we have allergies, we might buy a Claritin or an Allegra, or things like that, right? Over the counter. These are all over the counter medication. So histamine 1 receptors, and we take advantage of blocking these receptors, thereby blocking the allergy reaction, hoping to cause some relief with the allergy symptoms by giving drugs named I think it's fenofoxatine, or maybe I think there's a typo there. We have to look up. Sorry about that. So loratadine, cetirizine, and diphenhydramine. You guys have heard Claritin, right? You probably know Benadryl, Claritin, and Zyrtec better than these generic names. But you do need to know the generic names. That's diphenhydramine as Benadryl, cetirizine as that, and loratadine. So Benadryl is more of an old generation, histamine. What happens is that it kind of can cause drowsiness and sedation. If you look at the sheet right there, versus compared to the newer type of new generation ones like the cetirizine or loratadine or the phenoxetine, you have lesser of those problems, drowsiness or sedation. Okay, so if you look at the mechanism of action, it says compete with histamine at the H1 receptors, bind to unoccupied H1 receptors, prevent signs, symptoms of allergic response, prevent vasodilation. You don't need to know everything, but just know what I told you in terms of H1 receptors blocking and thereby helping with skin or lung, signs, symptoms. It says here H2 receptors in brackets, chapter 50, H2 blockers. We will review them when we do GI drugs, okay? So generally, if you look at why we give this, we give it for when patients might have problems with the allergies, of course, right? But with diphenhydramine, it has to be used with caution, not only in the elderly, but very much in caution when people are on other CNS depressants, which we talked about before, right? We learned about so many CNS depressants, starting from the barbiturates to the anti-epileptics to the, opioids and things like that. So this is one group, antihistamines given mostly for allergic responses for the upper respiratory drugs. The choice of giving for allergies is higher with, it's better with loratadine and cetirizine. The one challenge with cetirizine is that it could elevate liver enzymes, so we should be careful to teach patients not to take more than 1 in 24 hours. Very rare severe side effects include myopathy or rhabdomyolysis. One way to remember this could be to remember the histamines end with amines, right? Amines, which you learned in chemistry. So if you look at iodine, cetirizine, you can add an E there. So everything will be like an ion. If not an amine, it's an ion. So the amine is the older one. Everything else with INE is a newer generation. You guys got that? That's a nice little way to remember. Because diphenhydramine especially can cross the blood-brain barrier, you need to be really careful with CNS depressants and teach them exactly what you would teach in terms of, operating machinery, and then for dry mouth, what to teach them and things like that. So caution in cardiac or renal. Sorry, guys, there's a typo. All right, so the next is decongestants and antitussives. So if you look at these two groups, these are mostly over the counter. I wouldn't expect you to know everything in detail, but we have done some of these already, right? So if you look at opioids, they've already done that. When we look at anticholinergics, we've already done that, right? So let's look at decongestants. So decongestants, again, are given for symptom relief. So it's right here. So there are different types. Adrenergic usually dry us up, meaning there are sympathetic responses. So phenyl or Sudafed or phenylephrine, right? Ephrain is based off epinephrine, right? So that's Sudafed. It helps with the vasoconstriction of the upper respiratory tract. So it's very specific to the upper respiratory tract, this medication, and it helps in, kind of reducing some mucosal inflammation in the nose. So if someone has severe rhinitis because of, allergies and they're very stuffy. But nowadays, the recommendations are to keep, healthy nasal mucosa by using, saline sprays and things like that, and to preventing those allergies. But if it gets worse, then you need something. So that's when the Sudafed. The problem with Sudafed is that it could cause addiction in some individuals. And also caution to teach them about it. And it can also cause rebound congestion. Okay, so something to keep in mind. So if you look at anticongestants, if you look at adrenergic, we have only one medication, that's the phenylephrine, and we need to really teach the patient about addiction and the risk for rebound congestion if they continue for taking for more than 4 days or 5 days. So the next group of decongestants is anticholinergic. So if you think of anticholinergic from your past, sludge is the mnemonic that you remember, right? It keeps you dry. It still has a sympathetic response, right? So the name of the drug is ipratropium. So the things that have this trope in the middle is anticholinergic, is used for respiratory, issues. If you go back and think about your autonomous nervous system and you compare sympathetic to parasympathetic, the sympathetic is helping to bronchodilate, right? So that's what it's trying to do, dilate everything. So when there's constriction, it helps the anticholinergic, but it dries the rest of the body, right? So they'll have trouble with urination, defecation, things like that. But when it's in its spray form, the ipratropium, and given in a spray form, it doesn't have as much of the side effects like a PO medication. So another medication that can be used for relief of this inflammation or decongestion is corticosteroid. So the ones that end with ones, fluticasone, there's more drugs that you'll see in the lower expiratory drugs, like I think you might have budesonide and prednisone. So those ons, those are corticosteroids. So they help again with that inflammation by reducing inflammation. Those corticosteroid, meaning they contain the cortisol part of it and the steroid portion, and they are secreted from the adrenal glands. So you give this in a tablet form and help them to reduce inflammation. So it's a very potent anti-inflammatory. So thereby it prevents decongestion. So these three are the categories of decongestant. So adrenergic, anticholinergic, and corticosteroid. So the last group of upper respiratory drugs is to think of opioids. Opioids are not by themselves used for cough, but let's say a patient has morphine, but if they take it, sometimes if they have cough too, it kind of helps with both, right? But the challenge is respiratory depression if given in large doses, so something to keep in mind. But in general, it's combined with codeine, and it's available even over the counter, but the dose is very little. The dose of opioids will be very little, codeine-based products, right? Because it does suppress the cough reflex in the medulla. That's how it works, especially codeine, not as much like hydrocodone. I think codeine is one of the really potent. So with robitussin and dimetine over the counter, it's useful. So the side effects, right? So that's all you need to know about opioids. Non-opioids like dextromethorphan, which is available in like a